Good morning, Peter Goertz. I'm a psychiatrist. Boundary issues with psychiatric patients. Have I always done an excellent job regarding this? Probably not, but I'll give you a flavor of what I've done over the years and a sense of my experiences. This issue came up recently because in our clinic there are a lot of no-shows, a lot of late cancellations, so cancellations within less than 24 hours. And that means that other patients cannot get those appointments. So they're just empty appointments and no patient is seen and the clinic loses money. So it's an issue and it can be something in private practice you upfront tell the patient about. You're gonna have to pay for missed sessions or for late cancellations within less than 24 hours. But in general, in clinics, at least often, that cannot be done, possibly because the insurances don't allow it. I'm not entirely sure. And another issue that's connected with that is, let's say a patient comes, they have an appointment for 9 o'clock, their appointment's for half an hour, they come at 9:25 and then want to tell you a lot of things and want their medications adjusted. So that's another aspect where the appointment is not necessarily lost, but minimized, and the patient may be potentially asking you to run late, which is not fair to the next patient. So all these things can be problematic. As far as no-shows, it depends on your clinic's policy. And what's important, in my opinion, is to tell the patients that it's just not fair to other patients who are waiting for an appointment for months and can't get one when your patient doesn't show up, and that would be an available appointment for someone else. And the same with late cancellations. With lateness, you also want to talk with your patient and let them know that it's not fair to the next patient if you run late. Depending on how you practice, I like to see patients on time, and that way it's easier, in my opinion, to set boundaries with patients regarding lateness. If you start on time, then they know that it's fair for them to be on time and that you don't need to run over if at all possible. It can happen in urgent situations, of course. Another thing that can happen are racist comments, prejudicial comments, and you hear a lot as a psychiatrist. And what I've done over the years is we can't change people's beliefs in an instant, at least. So if people are racist or prejudicial, that's the way they are. So we want to accept them as human beings, in my opinion, but we don't want to buy into that or pretend to buy into that by making similar comments, for sure. Now, one example, sometimes things can be subtle. People can make subtle, racist, prejudicial comments, but sometimes it's very in your face. I used to work in a clinic where once a week they would have groups for homosexual, bisexual men, transsexual men. And then it would be visually pretty obvious, because of the way some of these men dressed, that there was something going on in the clinic. And another patient of mine came to that clinic, asked me with a disgusted, angry face, "What is this, a fag convention?" And again, we can't immediately change people's beliefs, but we definitely don't want to make similar comments or make comments that may be construed as us agreeing with the patient's opinion. Same thing with jokes that can happen, jokes that may be distasteful to you, cursing. People can curse in ways that are over the top sometimes. Another aspect, years ago, a patient used to come to my office with urine soiled pants. And I did not want him to sit in the regular seat because I didn't want that seat to be soiled. So specifically for that patient, actually, I had an extra chair, plastic covered chair that could be wiped clean. And that's the way I dealt with that situation. Conceivably, you could tell the patient you can't come to the clinic, if you have urine soiled pants, but some people are not able to function very well, may have some cognitive deficits. So I didn't want to exclude that particular patient from the clinic. You don't want patients bringing drugs into your office. Once I had a patient in my office just open up, take something out of his pocket, and what it turned out to be was methamphetamine. So you want to try your best to avoid that. But of course, you can't control everything. That type of thing can happen. But if at all possible, you want to avoid patients bringing drugs to the clinic. Another issue often is a family member comes in with a patient, let's say a wife, a daughter, son, and they come to the clinic with the patient and they want to be seen, they want to be in the visit. What I almost always do if it's a new patient, unless there's some specific reason to do it with the family right away, which I can't really think of, but what I generally do is, even if the patient's obviously demented, probably won't talk much, I still, for a new patient, I want to initially speak alone with the patient. And then, even if it's just 5 minutes, then I go and get the family member if the patient is okay with that. And one reason to do that is the family member may well not know everything about the patient, like a criminal history or sexual history of abuse. So you want to give any patient, even demented patients, the opportunity to open up about things that they may not want a family member to know. So what I generally do is ask the patient, is there something you want to tell me in private before your family member comes in? Another situation where you want to be careful not to feel obliged to do things that you wouldn't usually do is, let's say, if you see a relative of a staff member, maybe even a high-ranking staff member in your hospital, you may even subconsciously feel obliged, I have to do an especially good job with this patient, which you don't want to get into, in my opinion, you don't want to get into that type of thinking. You want to treat every patient with the same respect and with the same process of treating that patient that you usually use. So you want to try your best to be aware of things, aware of potential issues, like you want to do a good job, of course, and if you don't do a good job, the high-ranking staff member who's a relative of the patient may hear about it, but still, you want to try your best not to be influenced by that. What I used to do before electronic messaging in a clinic was to take phone calls from patients, even during other patients' visits, which is debatable. It's debatable if that's the best practice, but that's what I used to do, even very briefly. So sometimes I would say, I'm busy right now, I'll call you back. But often I'd talk for a minute. If a patient was suicidal, asking what to do, they knew they could reach me directly pretty much between 8 and 5 p.m. except for the lunch hour. So that already was kind of potentially like a security blanket for patients, knowing they could reach me directly, even if it was just for a minute. So that worked pretty well. Actually, for years I did that. Even if a patient was sitting in front of me, I would answer the phone if another patient called and just briefly talk with that other patient. And then the patient also in front of me knew, of course, that when they called, that I would also take that phone call. Not ideal, but has its pros. And now with messaging, that's not an issue, for me at least, but what can be an issue is some people send very long messages, written messages. So you may want to talk with the patient about that and ask them to send a brief message. And if there's something longer to address, you can always call them and briefly talk with them on the phone. Another aspect that can be tricky is if a patient asks to hug you, which often is fine with me, but if you feel there's any chance there's a sexual attraction from the patient's point of view or from your point of view, you don't want to hug a patient. And at another level, if a patient asks you out, not a good idea to have a date with a patient, of course, and you can be open about it. You can say, it's not a good idea. I'm your treating psychiatrist. Thank you.